Welcome to AI in Public Health, amplifying our ability to meet the needs in our communities. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum alongside my colleague Jeff Bornstein. Thank you to our partner for today's event, the Public Health Institute. And now it is my pleasure to introduce the moderator of today's event, Dr. Carmen Rita Nevadas. Carmen is a senior advisor at PHI Center for Health Leadership and Impact, founder of Dialogue for Health, and senior vice president emeritus of External Relations and Preventive Medicine at the Public Health Institute. Welcome, Carmen.
Thank you, Merlene, and welcome to everybody. We're really glad to see you. There's tremendous buzz about artificial intelligence in a range of spaces, but in public health, we know it has both tremendous potential and significant risks. We hope by the initiation of this Dialogue for Health AI series that we will stimulate that conversation further and get to the questions that you, members of our audience from across the country and a variety of viewpoints, will most surely raise. In the first episode of this series, we'll bring a discussion that is only an overview, but where we hope will surface many issues of interest and concern to many of you working in the field. Based on the interest you show, we'll offer a second web forum in which we can present working applications of AI in the field and supporting the public health mission. In the third, we plan to hold a workshop that will highlight user-friendly tools that you might employ in your AI exploration journey. So to start today's conversation, I'm pleased to present Melissa Stafford Jones, who's the president and CEO of Public Health Institute, who has personally shown great interest in helping to forward this agenda and who is sponsoring this web forum. Merlene, will you please run her video?
Welcome, everyone. I'm Melissa Stafford Jones, President and CEO of the Public Health Institute, and I'm pleased to welcome you, our participants and our presenters, to this new PHI Dialogue for Health webinar series on AI and public health. PHI is sponsoring this webinar series to help us come together and be in dialogue about this really critical issue to explore at the intersection of AI and public health. And I think there are three issues that are driving us to really want to come together and have this dialogue with all of you in the coming months. One is the possibility, the potential for AI as a tool for public health innovation and impact, and its potential to really help us transform and strengthen public health practice when used thoughtfully. Secondly, we know it is critical to think about how do we center equity in the design and use of AI. We know that technology is not neutral and that we have to be thoughtful and with a critical eye toward thinking about how AI can be developed and deployed in ways that are equitable, inclusive, and really grounded in the real and lived experiences of communities in order to be thoughtful about the design, the data we are using, the decision making that is happening as a result of AI to truly advance public health outcomes and address health equity. And then thirdly, there is the possibility for the opportunity for AI to be part of our tool set in reimagining public health systems through the responsible use of AI. And we know this is such a critical, complex, and challenging time for public health and the broader health ecosystem. And where work on redesigning and rethinking our systems in this time of such significant change is really critical work for our field. And so this is an important question to be asking ourselves potentially is what role might AI play in helping us to do that redesign, that reimagining? How might it help us gain better insights from the use of data, opportunities for more streamlined and effective public health practice processes and work, and really centering the experiences and the insights from communities in that work with the right humility and guardrails to ensure that even with the use of AI, public health systems are deeply community-centered, trustworthy, just, and oriented to the outcomes that we have as public health leaders and practitioners. So we are just really pleased to be launching this series, and we really want to invite all of you, our participants, our colleagues, our presenters, to be in dialogue with each other and with us around these issues to help identify the questions we should be asking and exploring as part of this webinar series about how we define the role of AI to advance public health and health equity. So thank you for being a part of this series. It will launch with the first webinar, which will be an introduction to the topic and serve as the foundation for the series. The second webinar will be in the fall and will include practical examples of AI use in public health. And then the third webinar in the series in the winter will be a workshop to demonstrate AI applications and their potential use in public health. So thank you for being a part of this series. We look forward to the dialogue, the conversation, to the learnings that we will have together on this critical topic.
Thank you so much, Melissa. Okay, well, it's now my great pleasure to introduce our speakers. After I tell you a little bit about each of them, they will set the stage by sharing some insights about AI from their perspectives. Then after they share their thoughts, we'll go to questions. But this is a conversation, so please put your questions into the Q&A and feel free to share your reactions. It makes for a better conversation using this platform. John Auerbach is one of our presenters today, part of our panel. He's held senior public health positions at the federal, state, and local levels in both government and non-governmental organizations. As Boston's health commissioner for 9 years, he directed homeless, substance abuse, emergency medical services for the city, as well as a wide range of public health divisions. During his 6 years as the Commissioner of Public Health for the Commonwealth of Massachusetts, he developed innovative programs to promote health equity, combat chronic and infectious disease, and support the successful implementation of the state's healthcare reform initiative. He was an ASTO board member throughout his tenure and board president from 2010 to 2011. He was previously the Director of Intergovernmental and Strategic Affairs for the Center for Disease Control, serving as the strategic advisor on CDC engagement within the tribal government agencies at the federal, state, local, tribal, and territorial levels, public health partners, and other external partners. Earlier in his career, Auerbach was the CDC Associate Director and oversaw policy and the agency's collaborative efforts with CMS, commercial payers, and large health systems. For 5 years, he served as the president and CEO for the Trust for America's Health, where he oversaw TIFA's work to promote sound public and make disease prevention a national priority through research reports, communications campaigns, and government relations. Let me also take the minute to introduce Alejandra Casillas, who is a physician and associate professor of medicine in residence at the Division of General Internal Medicine and Health Services Research at the David Geffen School of Medicine at UCLA. She practices primary care at UCLA and teaches medical students and internal medicine residents while caring for patients at the Venice Family Free Clinic. The first in her family to attend college, Dr. Casillas completed her undergraduate studies at Harvard College and medical training at Harvard Medical School, where she received the Dean's Community Service Award and was a Paul and Daisy Soro Scholar for New Americans. After finishing internal medicine and primary care residency, she returned to Los Angeles as a Robert Wood Johnson Clinical Scholar, where she completed a Health Services Research and Leadership Fellowship and received a master's degree at the UCLA School of Public Health. After completing her training, Dr. Casillas worked at the Academic Medical Center in Geneva and Lausanne with funding from the Swiss Office of Public Health to address immigrant health disparities in French-speaking region of Switzerland. Dr. Casillas' community-engaged health services research focuses on low-income communities served by Los Angeles County Department of Health Services, the second largest municipal safety net in the United States, developing digital health interventions tailored to socially complex, limited English proficient patients. Her published scholarship also includes research and initiatives addressing equity and diversity and inclusion in academia and health, connecting as PI on several NIH-funded implementation science and health technology studies. She's co-lead faculty in the Community Engagement Research Program at the UCLA Clinical Translation Science Institute and Associate Vice Chair for Community Impact in the UCLA School of Medicine. So we welcome both of our speakers. And I want to start the conversation off by asking each of you, starting with John, to discuss your connection to artificial intelligence work and how you became involved and interested in this field. So John, if you want to show some slides, please go ahead.
Well, thank you. Let me start just by saying hello to everybody and giving a special thank you to you, Carmen, for your continued leadership and educating all of us and your dedication to the field. And it's a pleasure to speak alongside of Alejandra as well. As you heard, I'm a public health guy. I've worked for 30 years at the local, state, and federal level. And now I have the pleasure of working at ICF, which is a Health and Human Services consultation firm. It's very much focused on AI and IT expertise. If you want more information about that, just Google ICF Fathom, which will tell you the full range of different activities that are available at ICF related to AI and IT. I myself am not an IT expert. What I am is a public health practitioner. And so what I understand is the potential of AI to be useful in terms of the day-to-day and ongoing important work that takes place in the field. My interest in AI is advancing public health and promoting the health and well-being of the public. It's not looking at it as the latest shiny toy. I'm also not what you might call a cutting edge IT guy. People used to joke that it's only been a few months, I'm not carrying around a BlackBerry phone. I evolve very slowly when it comes to IT. But I really can see very much in practical terms the real advantages of artificial intelligence in terms of supporting public health efforts. And that's my interest in being here today. I also recognize, as Carmen indicated, that there are dangers we need to be aware of, challenges to AI that require that as we think about it and plan for it, we put in place safeguards and make sure we're planning from the beginning in very careful ways. Now, why I'm very much interested and supportive of AI, I understand that AI is still a new concept for people in the field of public health, that is. In NACCHO's most recent survey of AI, only 5% of local health departments indicated that they were currently using AI. And a small percentage indicated that they were even anticipating that it would be used. And so there's a lot of attention to try to alter that because public health does not want to be left behind as AI is utilized throughout the country and all the other sectors. NACCHO, in its conference, which was just about 10 days ago, its NACCHO 360 conference in Anaheim, really focused a lot of attention on the potential of AI for the public health field, and ICF itself was involved in a plenary session on that. And when we focus on it, we focus on some concrete efforts. So let me move now to what those concrete benefits can be for public health. So first in this slide, there are 4 areas that I would say for me come to mind as immediate places to start in terms of thinking about AI and public health. One is on communication. AI can be very helpful in terms of ensuring we have multilingual, multicultural educational material, something that the public health field has not been strong in. I've worked at the local, state, and federal level, and often we didn't put out materials that were culturally sensitive and linguistically appropriate. AI really helps in terms of that. Is it perfect? No. Do you need to make sure you have people in the loop to check? Absolutely. But it offers tremendous possibilities. You also can focus on subpopulations, like, say, people with disabilities or people who have particular concerns because they're immigrants. So communication, a lot of potential. Administrative tasks is another topic. One of the things that occurs all too often in public health is we have to do tedious day-to-day tasks that are not really about advancing the field. They're about getting paperwork done or fulfilling certain kind of requirements. And there too, it can be very helpful to tap AI. I'll give one example. If any of those of you who've been involved in changing regulations, public health regulations, know you need to solicit input from the public, and you can get hundreds and hundreds of inputs, and then you have to analyze them and decide what are the key issues to focus on. There is a tool called CommentWorks, widely used by the federal government, that simplifies that process by tapping AI to consolidate that information and put it together in manageable units that allow quick access. Third item is enforcing regulations. Unfortunately, while public health is involved in enforcing regulations, be they food related or smoke related or community sanitation, we often don't have enough resources to regulate everything, and we need to make choices. AI can help you in terms of making wise choices. Chicago is an example where they looked at their food establishments and the fact that they didn't have enough personnel to monitor them all, and they used complex data in a formula that allowed them to help prioritize where to go first as they were doing food inspections. And they found that they were able to find more violations using that kind of systematic approach. Finally, surveillance and assessment, the heart and soul of public health. This is another area where it can be helpful. I won't go into too much information about that right now, other than to say it can be very helpful in combining data sources that in the past and in the present have been challenging to combine. If you're looking to combine health data sources from, say, BRFSS or BioSense together with social and economic factors, AI can help you to merge those different databases so you can get a community-specific profile, sometimes at a granular level that weren't possible before. But where do you start? We're going to talk more about that in the discussion, but starting with having guidance and principles in place, rather than just starting by using AI, can avoid some of the problems. You want to involve your staff, you want to involve community members and partners, and you probably want to start simply identifying a few key problems. Next slide. I'm just going to give you two quick examples and then turn things over to Alejandra. I used AI recently when I was conducting a focus group for about 14 different health officials around the country who had been involved in wastewater surveillance. They came from very different locations, rural and tribal and urban. And we had a lively conversation for an hour and a half. And the goal was to produce an effective white paper. Within minutes of the end of that focus group, I was able to get a written transcript of the conversation and then attach it to an AI chat, and then say, here's, with a long description, here's the draft I would like to see. Very important to have a very specific prompt about what you wanted to see, what the goal was, what the language was, what the sections of the report should be. But that printed out within 5 minutes. That gave me, within half an hour of the meeting, a really solid first draft of what could be a white paper. Had I not had that, I'd have been working on that for at least a week to get a draft. Now, that draft was a first draft, solid first draft, but it needed to be carefully reviewed by me and the other people who were in the group, and then by everybody who participated. But the final document was probably 85 to 90% of what was originally just printed out in the minutes after that focus group. One other quick example, next slide, please. This was a contract that ICF had with CDC. CDC was trying to develop some additional information about school closures as a sign that there might be a health problem in communities where the information could be captured quickly if there was a school closure. But monitoring school closures across the country, 120,000 schools and school districts, wasn't really possible. Schools don't have to report their closures, say, to CDC or to anyone else. But developing an AI app, we were able to screen via social media those 120,000 school districts and determine how many of them were being closed that day. That allowed CDC to focus its attention not on looking at Facebook and other social media endlessly, but simply by looking at the list that had come up on the screen as being closed for an undetermined reason or for a reason that sounded like public health. That cut out hundreds of hours of CDC time, allowing them to get real-time or close to real-time information about a potential health problem. So with that, I'm going to stop and turn things over to Alejandra, and we look forward to your questions and comments. Thanks.
Thank you, John. And I have to say, having gone to medical school in Boston, when I saw that you were going to be on this panel, it was a great honor. So I humbly come to this space. Thank you, Carmen and Carmela, for the invitation. My name is Alejandra Casillas, or Ale, as my friends call me. And I'm a primary care physician and a health services researcher. And I think I'm glad they used sort of the detailed bio for me, even though it was a little bit long in the introduction, because I think that sort of gives you a sense as to why I come to this space. Also not being someone that is, the AI guru or the ML expert, but someone that has the perspective of integrating lived experience and community voices into any advent in healthcare and quality of care for health. And so let me just tell you a little bit about my background. As I mentioned, I'm a primary care physician and health services researcher at UCLA, and I've always been interested in care for folks who come from underserved backgrounds, given my lived experience. And from the get-go, was very interested in health education, health communication, and how that impacts quality of care for these populations. And so had worked on that at the beginning of my career. And then, as you heard, I went abroad for a few years and worked in immigrant health in Europe. And at that point, I was working at Venice Family Free Clinic. We were still, using paper charts. For those young people in the audience, we were still writing paper notes and putting our orders in a folder at the nurse's station. But then when I returned back from Geneva and Lausanne in 2016, everything had changed. So, the ACA implementations that had gone into effect, the ones that were from 2014. And now everything was electronic. And I was really perplexed and interested in knowing, now as a new faculty at UCLA conducting health services research, how was this going to impact people from my community that I was taking care of, my patients at Venice Family Free Clinic, the people that I was partnering with in the LA County Department of Health Services. So not having really any digital health experience, I would say, kind of dived into that whole body of work and was initially there wasn't a lot of interest there for these populations. I think pushback that I got at that point, and at that point it was, integration and implementation of patient portals, telemedicine, telehealth. How would this affect the safety net? How would this affect limited English proficient populations? And I think at that point the pushback was, well, these patients, they can call on the phone or they can come in person, and so why are you even developing this body of research? And they're not interested. They're not interested, even though we're implementing this new clinical tool. And then guess what happened? You all know what happened in 2020. The pandemic happened. And then all of a sudden, it was very important to make sure that everybody had access to digital health for access to care when a crisis was happening in the public health setting. And it was really important that everyone was able to register for a vaccine online, et cetera, et cetera. And this really played out, as we saw, not just in healthcare, but in other parts of the social determinants of health in impacting and widening disparities. And so, I think in here in the slide is I put in community health voices in AI and ML mitigating the inverse care law. And I don't know if folks are familiar with what that means. But what that means is that for example, in healthcare, when we think about sort of innovation or an advent or a step forward, we're usually what we're doing is, for the most part, catering to the mainstream. And then what happens is that the people who actually need that advent or innovation the most, or who could be served the most, as John mentioned, great potential to address disparities and bridge equity and bridge gaps, actually they get more left behind, and we make things worse for them because we say, well, they don't need this, or they're not going to use it. And I'm hearing the same conversations now around AI ML. Well, why do we need to talk about ChatGPT with these populations? Or why do they need to know about how this AI tool is being formed for this healthcare setting? Same story. And then, another disaster happens, and then we see the fallout. So I think it's really important from the get-go to think about how we think about those at the periphery and center them, rather than think about them as an afterthought, in order to mitigate the inverse care law. And so that's sort of the perspective that I bring to this conversation, in terms of the viewpoint. And I think just stemming from my experience in my health services research and also in my past background. So we'll go to the next slide. Here, it's just a reminder. It's a great slide from my colleague, Dr. Medell Briggs-Melanson, who's our Chief Health Equity Officer at UCLA, and who also herself has worked with the Office of the National Coordinator for Health Information Technology, one of the 3 agencies right now, or who had been up until this point, overseeing the development of health AI. Just a reminder of the important social structural drivers of health, and technology here being one of them, and also thinking about how, with regards to health technology, one of the advantages here, or the potentials, is really bridging all these different sectors in terms of impacting healthcare and public health, using data streams from all these different sectors to make appropriate decisions about people's healthcare and their livelihood and their quality of life. So I think this is just a really nice reminder that technology, yes, is one of these social drivers, and actually a social driver that can incorporate the rest of these social drivers as well in our decision making. We can go to the next slide. I just want to give a shout out before I even begin talking to all the community partners who have really informed the work and the perspectives that I'm going to bring to the table today. I talked about the beginning of my research back in when I started in this work in digital health in 2016. And as digital health has continued to expand, as our work has continued to expand, we've really learned a lot from our community partners. And we've been lucky at UCLA to be able to have been partnered with many community-based organizations through our community engagement research program, through our Department of Medicine's Office for Community Engagement and Inclusive Excellence, through our partnerships with the LA Safety Net, which includes the Department of Public Health, the Department of Mental Health, and the Department of Health Services. So, what we've learned is not just something that we've learned overnight. It's a result of years of working together and building relationships with the LA community and the greater LA community and those community members. And what we've heard from much of the work that we have, and I'll talk about one initiative in specifics just in the last couple of slides. Much of the concern that we've heard on the ground is, that this technology is growing quickly, and as we have alluded to, has potentially left some people out already. And that gaps will be created or widened. We talk about this emerging tech to communities, and some are excited, but some are scared and they have fears. And I think we have to acknowledge the history of that, and not just in healthcare, but the history of automated tech or automated decision making, automated policies in the past. Because this type of automated technology or automated decision making in the past has not been kind to Black and Brown communities. We can quickly look at, it doesn't take an intense Google search to know what has happened to Black and Brown communities when it comes to, for example, loan applications and redlining in cities and urban planning zoning of neighborhoods. And already some recent examples with health technology and biases in terms of diagnoses for darker people for germ pathology using specific sensors, or the faultiness of certain pulse oximeters on darker skin. where again, Black and Brown communities are getting poor quality of care because the technology is not built with them in mind. So, these are the examples that it's really quickly come up to the forefront because it's not wrong, it's correct. And so we really have to be mindful and intentional about the way we progress with this emerging technology. So we'll go on to the next slide. So I think what I would like to do is make sure as we continue on in our discussions and conversations and these questions, think about, there are many frameworks out there, but I brought up one here from the Office of the National Coordinator, which I mentioned, which is one of the agencies that's helping to oversee the advent of health AI, at least in clinical care, thinking about these 5 principles of digital health equity, which aren't only applicable to AI ML, really to any technology that's incorporated in health. So to start off, inclusive representation, right? So that data and applications should be representative of all those that may be impacted, and really intentionally looking for and including represented and vulnerable populations, and engaging and incorporating diverse voices and vantage points along the entire technology lifecycle. So that goes from design to development to deployment and assessment. Second, one that I think, I think these are all important, but one that I study a lot in my work for digital health implementation in the safety net is accessibility. And really the fact that not just being able to access the tool, but also the fact that the data belongs to the people. So at the individual level, thinking about access on the spectrum of diverse abilities. John mentioned linguistics, linguistic alignment, language, socioeconomic considerations, affordability, digital and technology literacy. At the community level, thinking about the infrastructure of this information technology and whether it's accessible to that community, and then having direct access to community level data. And at the organizational level, also thinking about the accessibility via financial resources and structural capabilities and interoperability between systems. Number 3, I also wanted to, mention this important concept of privacy, which on the ground with our communities is an important one. We need to really ensure human-centered privacy, and at all levels assess the intent of the technology and ensure its appropriate utilization, and being transparent with that with our stakeholders as we develop, as we implement technology in whatever settings we are in. We need to be aware of and respect individual and community responses to various forms of data and technology being used. We heard about the fact that we have tribal populations here in attendance, so we think about biometric data, we think about all these things that are important. And we have to obtain informed consent due to historic and modern discrimination, as I mentioned, for wrongdoings and with technology and specifically in healthcare. Transparency, I think, is an important principle for all of us as leaders, whether it be in public health or clinical care or community engagement, committing to full transparency from data collection, analysis, utilization, and transparent about the tools, known biases, whatever you're going to use, or poor performance, and being accountable for that. Ensuring that patient and provider-facing communications are at the appropriate literacy level and language concordance, and non-technical jargon for providers as well, in terms of that tool being transparent. And I think the last one, and obviously I care a lot about accessibility, that's what I work in, but yes, doing no harm with any advent in technology. We have, like I said, the great potential to actually make things worse. So we have to be very intentional and very, very aware in assessing these new tools for potential discrimination, bias, or harm along the entire technology life cycle. We have to recognize biases and structures that perpetuate racism and other forms of discrimination, because these tools are only as good as the data that they're getting. And we are humans and we make mistakes, and we are the people that provide that data. We have to build questions upon existing frameworks and algorithms, continually assess those algorithms that are being put out, and continually, think about doing initial simulations on real world data to make sure that we are looking out for any harm and bias prevention in those potential tools. So I'm going to go on to the next slide. Now that we have maybe just thinking about this principle of digital health equity as we continue on in this conversation, I wanted to mention one initiative that I'm specifically involved with at UCLA as a leader of the West Hub of this initiative. And so I wanted to introduce AIM-AHEAD to all of you, which stands for Artificial Intelligence and Machine Learning Consortium to Advance Health Equity and Researcher Diversity. This is an initiative that was created by the NIH Office of Data Science to increase the participation and representation of researchers and communities that are currently underrepresented in the development of AI ML models to better understand and address community health needs across the country. It was motivated in 2021 as we were within sort of, the throes of the pandemic by the fact that we were just generating so much more EHR data. So it started with sort of an EHR notion that we had a lot more complex volume of data that was being generated by NIH supported investigators. And so we also knew that the technology was continuing to grow, and we wanted to see more diversity in not just the databases that we were seeing, but also its researchers, processes, and whatnot. And so this was the motivation for AIM-AHEAD, and it has really grown in its breadth. I won't talk about all the things that AIM-AHEAD does because I want to really focus on our conversations, but I can show you here in the next slide in terms of the community engagement part of our AIM-AHEAD initiative here at UCLA, where we've been based. Our community engage initiatives for AIM-AHEAD have really helped us understand and implement some programs to address some of the issues that I talked about in the first few slides. Specifically our conversation cafes, where we showed this movie Coded Bias from Netflix that talks about some of the inherent discriminations in algorithms, et cetera, and was able to use that as a way to stimulate conversation, focus groups from our partners at Charles Drew University. Here you have Cynthia Gonzalez leading a conversation there with some of the panelists and folks in the audience about some of the concerns of AI ML in those communities in South Los Angeles. We've always also been able to host over Zoom these tech equity forums where we are able to talk about some of the funded pilot projects that highlight some of the applications of AI ML tools in specific community health issues. So here we have Dr. Sobowale from UCLA who talked about his AI, his algorithm in predicting postpartum depression in specifically African-American mothers. He's a psychiatrist at UCLA, so he was able to talk. He's an example of work that we highlight in those forums through AIM-AHEAD, and also through these tech equity forums, we've been able to talk about how to use ChatGPT or the different AI tools available to people, and introduce the community members to some of these tools and hear what people are using and what they found, and hear their perspectives on that. And then as well through AIM-AHEAD, we've been able to develop and support digital health programs in the Los Angeles County Safety Net. And here specifically, you have the example of the Health Technology Navigator program that we've supported at LA County DHS, which is basically a program that includes on-site community health workers, who specifically help patients navigate health technology. So really starting with, just the basics of signing up for an email account and being able to download the patient portal and access it. And as well, through this mechanism, those navigators, we hope that also will be a platform to introduce other tools as people get more facile and more comfortable with, we'll call quote unquote the basics. As new AI tools come out in the safety net, this will be a core of people that will help introduce those new tools as well, so that these patients can use them. And we have seen, I can't go into the specifics, that specifically amongst our Spanish-speaking patients, interaction with a health technology navigator has made a great impact in people being able to use, what we say, the basic health technology, being able to sign up and actively use their patient portal for their healthcare, which makes a great impact in their access to care and their quality of care as well. I'm on the next slide. I'm just going to highlight. I'm just going to flash on the. I'm not going to go into the because we don't have enough time. I don't want to. This just gives you some example of other AIM-AHEAD opportunities. That the fact that we have a research and leadership fellowship that trains people around AI/ML tools, and also folks who are already doing AI/ML also helps introduce them to equity work as well. So that sort of we're kind of doing it's a dynamic conversation between the folks that are experts in the technology and folks that maybe are experts in the equity space and want more exposure to the technology. We help with access to data sets as well, and help. We work with Ocean to also think about access to diverse biomedical data sets, and also provide pilot project funding. You heard about Dr. Sobowali's work. I just put up the web link there in case people would like to look further. But I just want to move on to the next slide and maybe bridge the next part of our discussion. That I think my parting point is really, without it addressing digital health equity and using that framework, we run the risk of worsening health disparities, and actually we run the risk of producing a worse tool and a worse product. So I really think this is important to keep in mind, especially as technology has played and will play a more definitive role in the way we care for, I would say, for my patients and for those who are in the public health space for populations. So again, thank you for letting us come here and have this conversation.
So thank you so much, John and Alejandra, for getting us started on this conversation. There's so many touch points that we have here. The audience has asked some truly excellent questions in their registration, and they're throwing some good ones up for us now. A couple of things I just wanted to say before we get started on the more interactive part. We got 20 questions from the audience. Thank you, thank you, thank you. Really good input. Some of those we're going to refer to the second webinar because they are a little bit more specific to the people that are actually doing the work in the field. But we've had a chance to review them and incorporate them into the comments so far, and then we're going to try to incorporate them as much as we can into our next set of conversation. Please do feel free to throw your comments into the Q&A. It's so helpful. So let me start with this. I'd like to know where you think, what you're thinking about the kind of leadership and vision that we need to appropriately engage AI in public health, and who are some of the partners that are providing that leadership right now. John, I know you just came back from nature. You're probably full of ideas, and Alejandra, you can speak to what's happening a little bit more on the academic side, and probably also what's happening in the community health center side. So what kind of leadership and vision, and what do we need to be appropriate?
Well, yeah, I'll start with some ideas and then turn things over to Alejandra. Certainly for those in governmental public health, it's really important to work closely with your membership organizations. NACCHO, ASTHO, Big City Health Coalition are each doing educational programs for their members. And when they have funding, they're doing more than that. They're doing technical assistance and ongoing training. So working with your membership organizations, I think, is really key. I would also say, though, that one of the nice things, one of these potentially very positive things about AI is you can just also access things directly yourself. There are a lot of materials that are available and easily accessible about places to start. So let me give you an example about that. I think that just as Alejandra went through those 5 points that are the sort of key things to be thinking about as you're developing work around AI, that I think suggests that before you dive into it, you spend some time really understanding what those are. And there are a number of organizations that have developed useful guidance tools or principle tools, and just getting hold of those is a good place to start. I'll give you a couple of places where I would recommend. The Kansas Health Institute, together with Health Resources in Action, HRIA, did a terrific guidance document that's particularly for people who work in public health, either governmental or non-governmental. It really talks a lot about concrete and specific places to start, focusing very much on the issues of equity that Alejandra was mentioning, about the importance of community involvement. So I'd really recommend that. Also, NACO, the National Association of County Organizations, has actually done a good a good guidance document. So starting there with understanding the issues makes sense. The second thing I would say is starting not by putting people in a conference room, even a virtual conference room, and having the discussion only among a small group of people who are particularly data knowledgeable, but opening up the discussion both to people throughout your organizations and in the community at an early stage is a really good thing to do. When I was a local health officer, we would have regular meetings with the community where we would share data and say, did we capture everything? What did we miss? What are your concerns? Are there things we should pay attention to? Having those kind of meetings in a community setting, I think, as you're beginning to become more familiar with it, will help in terms of building trust, being well informed, putting in place protections so that you're more likely to get the advantages of AA than the disadvantages. Alejandra.
Yeah, John, I completely agree with everything you've said. And I think it's, the sort of, I think, what kind of leadership, I think about the quality of the leadership. And I think, one word comes to mind is sort of just centering ethics and equity always. And, that commitment, as you said, to fairness and inclusion, and thinking about, like, as I said at the beginning of the talk, those at the periphery, when we think about those at the periphery first, we actually will build a better product, we'll build a better tool. And so I think that's really important, having leaders that think about that specifically. I think also this concept of AI, I think thankfully is one of the advantages, is going to make different sectors have to work together. We've been so siloed. Especially here in clinical, even with clinical care, on the ground folks in primary care and public health, I feel like we've been so siloed in the information that we share and the public health information that I may be able to use to impact the care of my patient in the clinic room. I think as AI develops more, we'll have more tools at our disposal to help me think about, the way that I care for my asthma patient, for example, depending on the air quality in the environment, right? There's so much potential there in terms of cross-sector and interdisciplinary collaboration. So I think having that vision, that those leaders have that vision, that there is this potential to bring these different sectors together. And I think it's going to be imperative also that we bring different categories of expertise together. So, you said specifically in academia, I think we have to think about bringing the data scientists together, the folks in epi, the on-the-ground healthcare workers, even the ethicists, the community leaders. This is going to be really important. And this is hard in academia, right? Because we always have this. Obviously, I think we have this tendency that working with public entities is a good thing, but we also maybe have a little bit of a hesitation to work with the private sector, right? I know that we see this in academia, but I think there's going to have to be more collaboration with the tech companies, for example, who are people who are developing products, that we need to be collaborating more and talking about how they're building their products and integrating our voices in that space, because we run the risk of patients and populations then gravitating towards tools that are not evidence-based and that have not been developed with this, with these principles in mind that we're trying to put forward. So those are the things that I think about in terms of, the leadership that we'll need and the kind of vision that we'll need when we think about the future of AI in these healthcare spaces.
So great answers, and also a lot of great commentary from the audience. I'm going to get into one area where I think both of you will probably have quite a lot to say. How can we use AI to improve public health communications? Can nonprofits and government use AI to broadcast health coverage information to the widest low-income populations in several counties using Medicare and Medicaid, for example? Many have cell phones and internet, some have tablets and computers. So theoretically, they're accessible. How do we use AI to make that more effective and make it more efficient, and also really push the equitable nature of the potential for the tool?
I can speak a little bit to start. I think, as I mentioned, we have done in the last few years a lot of work on accessibility of digital health. And I think what we need to make sure we prioritize is still going back to the important fundamentals of digital health literacy, again, as a social driver, social structural determinant of health. A lot of our patients in the safety net, many, we introduce a portal to them and they still don't have an email account, or they have someone use an email account for them or has registered an account for them and they don't know they have one. or you have to sort of walk them through how to download an app. And I think with the development of our programs, be it developing digital health literacy tools for them, educational curricula, whether it be integrating their social networks or family members to help them with digital health. I think we have to find nuanced ways to make sure people are having the literacy to be able to access the tools. That's going to be a fundamental, what we call digital health determinant, because if we don't have those basics, then we really can't sort of even move forward. So as we develop new tools, I think making them very usable, very accessible, removing barriers, if we can do things where we remove the need for an email account, for example, where we're able to authenticate ownership of an account or accessibility to an AI tool in a different way for the individual, that would be great. Sort of removing all those obstacles for people in order for them to be able to access the tool. I think I'm trying to think about the first part of your question, Carmen. It was like, what are the potentials for? Can you repeat the first part of your question? Because I had some other thoughts about that as well.
Yeah. So the vision and actually I lost that. Sorry.
Well, I think John also said some really good things about
Yeah.
public health and multilingual, right? The fact that we can potentially translate things into many more languages that are what we call in language, right? In language in the area. Sometimes it's very difficult because there are certain pockets, certain neighborhoods where the number of in languages is much higher than the broader county. And so you have this capability. And now obviously with partnering with, hopefully a local community organization to make sure you vet the translation of that material, that it's culturally appropriate, that's being, sometimes the translation is not perfect, but it does open up the potential to be able to disseminate messages more quickly.
Yeah.
I also think I'm just thinking about like social media and the way the vaccine messaging to certain populations was so important during the pandemic. I did a lot of work during that time, talking to specific populations in culturally appropriate ways about vaccine safety and vaccine recommendations. And you can imagine that AI can be used to really curate what's happening in the internet and the social media space, those conversations, and to be able to target messages that will resonate with people's anxieties and hesitancies about a certain new, whatever it may be, treatment or tool, and be able to provide messaging that is in tune with what people are thinking on the ground. So those are some of the things that, I don't know if I captured parts of that question, but as you were saying that, those are some of the benefits that I thought in terms of communication to the public.
You caught that. Thanks, John.
I agree with everything that Alejandra said. And maybe I'll just say, on the horizon, there are other things that will be, and with AI, things move really fast. They're not on the horizon 5 years from now, 10 years from now. They may be next month. There's some creative potential uses. There's the use of avatars, for example, that can speak multiple languages, look like the population that's being served. And in some testing, people like that a lot, that sort of sense of, oh, I can get information with an avatar. That may seem really different from our own experience. And 2 years from now, that may be so common, we just take it for granted. The final thing I would say, which I think links up to Alejandra, is people get their information now about health from social media. And so we can't use old tools to give information out when people are getting their information with new tools, whether it be TikTok or it be innovative social media approaches. Public health needs to be involved in that and skilled at using it. And finally, we need to be looking for misinformation early. And if we have the right tools, the AI tools, we may be able to catch rising signs of misinformation so that we can nip it in the bud, if you will, speak to that quickly rather than waiting till like it's spread everywhere. And then it's much harder for us to catch up and to provide information that's more accurate. If we can catch misinformation wherever it's starting, speak clearly and specifically to it, that may help us in terms of avoiding some of the problems that we've had in the last few years.
So one of the things that a lot of audience members are asking in different kinds of ways sort of center around the ethical issues. I think you just touched on one, John. So maybe if both of you could talk a little bit about the disinformation potential. Would like to make sure that AI becomes a tool of supporting the dismantling of disinformation, and also that AI is a kind of tool that that does not end up propagating worse stereotypical thinking. So what are your thoughts there about how we bracket that thinking, how we can set up a stage in which we are anticipating the potential for going down harmful rabbit holes in that area?
Maybe I'll answer quickly and then turn it over to Alejandra.
Great.
You know, people may be now familiar with this term hallucinations. The hallucinations meaning that AI will give you the wrong answer. My colleague at ICF, Eddie Kirkland, I think says this, reminds me of this all the time, in that AI is not programmed to give you the right answer. It's programmed to give you the answer that seems right. So you can sometimes, it's out to please you. So it can sometimes give you information that's just not accurate. And there needs to be often what sometimes is referred to as a person in the loop, somebody who's looking critically at what's coming from AI and saying, is that accurate? Let me double check that. Let me fact check that in other sources. Let me look at how they're coming to that conclusion, pushing back, making sure that the request into AI is framed in a way that maybe minimizes that. So I think we always have to be on the alert for that kind of misinformation with AI. And again, if one does careful planning and thoughtful use of the guidance documents early on, it makes it easier to put in place the kinds of protections that makes it less likely that you're going to get false information.
Yeah, I agree with that. I think questions that as we think about potential harms, the first couple of questions that come to mind is, where is this data coming from? Is it ethical to use, and where is it coming from? And then again, the equity-centered framework, will it make disparities worse, or can it actually, help bridge equity? And so in terms of where it's coming from, I think we think about what the data source is. Again, the answer is only as good as the data. And it's like John said, it's not giving you the right answer, it's giving you the answer that it has. So, and that's going to be as good as the data. So think about the data sources, the collection methods, and then being upfront about those limitations. And I agree, it's someone that with the advent of these tools or the implementation, that part of the framework is having teams of people where it is their job to audit those algorithmic biases regularly, or do, I'm not a tech person, but I, heard the word like real world simulation, so it's like pilot testing, right? Where we do what we would do in research, we would pilot test an intervention, or in public health, we pilot test an intervention. I think you would pilot test these algorithms as well, and continue to test them and check them for biases. And I think also, as part of these processes, you need to have a community stakeholder at the table, or the population that you are serving, that the population whose data is being incorporated, community voices at the table as you're thinking about where you're getting data from, as you're thinking about the application of the data in these AI tools, and whether it's a health system or a public health entity, or a community-based organization using it. I think you have to have those stakeholders at the table during that whole process of evaluation.
John, were you going to add something?
No.
Okay, great. So one of the comments that's come up here is there's an issue. There's a really good question raised about whether using AI in public health could limit public health community engagement. So, we know that it's really easy to get siloed off into a column of non-concern. But how do we make sure, and how can we think about institutionalizing the kinds of structures that open up more public community engagement rather than close it down?
Well, can I have, I'll offer maybe an example that maybe it's not directly, it doesn't directly address the question, but I think it is related to maybe a little tangential, but I think it is related. And I see, I talked about our experience with the Health Technology Navigators program in the LA County Department of Health Services. And I personally am really hopeful and excited for the possibility of this technology to actually upscale our very knowledgeable on the ground promotoras, community health workers, people that are doing important work, and to actually empower them to be able to do even more with their knowledge base, using AI to potentially, guide care delivery, to screen for conditions for people, to help navigate them in their healthcare, to help people navigate their chronic disease conditions on the field. So I think that there is actually a lot of potential for community engagement with the introduction of AI, and that if we make sure that we make AI, whether it's working in AI or using it for health, if we make it accessible, this is important. I think for sort of the thinking about the workforce, that the community workforce, it can actually help upskill a lot of local health workers that are doing important work that are trusted by people, and help us actually augment the care that we provide to those populations. I'm thinking about the LA safety net. So I'm really excited actually for the potential in being able to do more with our community via AI.
John, anything to add?
What can you add to Alejandra? She says.
Well, one thing I want to just let the audience know, I put a couple of things in the chat for everyone to see, some really good resources that Eva Rios Benitez put into our Q&A. And just if you have any other resources, anyone in the audience, please get them in and we will make sure that everybody sees them.
That's wonderful.
So let's get on to another question, another concern raised by the audience. There are some really interesting ethical issues that were raised along. How do you balance the potential impacts, the positive aspects of AI in public health with the negative environmental impacts that also impact public health? And I thought there was a really good example given, which I'm looking for. I can't find, but there was a really good local example of how the ideal data centers, et cetera, in places like in Texas might adversely impact the public's health. So any thoughts about that?
I believe, Carmen, what the question may be referring to is the enormous amounts of energy that are used by AI, which is very significant, and particularly as we're grappling with more and more weather-related emergencies, it's important that we pay attention to this. I think that there is attention being paid to this now, and there's some efforts, I think, to try to reduce that energy footprint. And my understanding is different companies have different approaches to this. There's some that have been more responsible about minimizing the impact in terms of heat and energy. So I would encourage folks to, as you're thinking perhaps about a partner or you're thinking about someone to contract with, I would ask this question, what are you doing about this? It's a problem for the field. The field needs to work on it because that is not an insignificant issue for us to pay attention to.
Yeah, nothing to add. Okay. That's a really great point.
Okay, well, let me just go back just a tad and talk a little bit about, would you share your reflections on government public health use in decision-making using AI? Maybe John.
At this stage of AI, my inclination is that AI shouldn't be making decisions. AI should be a tool that people who are making decisions use and think about how it helps them to consider things that they otherwise wouldn't be able to consider. I think we want to do everything we can to ensure that the controls are in place that prevent harm. And to do that, you need to have a person who is paying attention to those, that is continually looking at that. That now I think there'll be times though, there's this what's referred to as agentic AI, where you can program an AI system to make certain kinds of decisions. And there may be settings where that makes sense, where it's just a simple yes or no, there's no potential harm, there's no ambiguity. You'd still want to make sure people design that really carefully and looked at it really carefully to make sure that you don't end up having bias or unintentional problems. So I wouldn't rule out the notion of agentic, the notion where it's the agent, but it's where the agent where you say, oh, I think this is a simple enough task or a clear enough task that we could rely upon certain kinds of decisions to be made. But I think we need to be very careful about that. And at this stage, I think keeping the person in the loop, particularly where it's a significant problem or a problem where the consequences could be serious and as Alejandra has said, intensify inequities, intensify problems that already exist.
Yeah, I agree with that. And I have like a little story to tell. It's more sort of thinking about my role as a physician. It was a conversation with my brother-in-law a month ago or so. And I don't know what study he was quoting. He's like, oh, and I think it goes back to this whole conversation. It goes back to AI versus public health, AI versus doctor, like which is better, that AI will replace the doctor or AI will replace public health. And, he was like talking about this study that they, showed a group of physicians diagnoses and they compared AI alone versus AI plus doctor versus doctor alone. And like, oh my gosh, AI plus doctor was better than doctor alone. So, AI is so much better. And my response was like, duh. Like, that's been, we as physicians, public health practitioners, we use tools all the time. So of course, when we have a new tool at our disposal, we are going to be augmented by that tool and be much better if we're using it correctly. And so it wasn't surprising to me that AI plus doctor was the best of the three. I would make complete sense. It's not the first time that we use a tool to sort of impact our decision making. And so I think the messaging really being that there's going to be change, but it's not. I think especially in our roles as public health practitioners, physicians, clinical health workers, our roles may be redefined and we may be pushed to learn new skills, but it's this blended human and AI collaboration models that I think will start to emerge, where the most important part will be sort of the human-centered system of AI, and also like the combination of our knowledge with this tool. And so this whole that question just brought up that conversation that I think it's going to be sort of understanding that we're just going to redefine our roles as this technology continues to emerge.
There's an interesting comment that came from Lakshmi Grama. Microsoft just published research that they've developed a tool that demonstrates diagnostic accuracy of over 85% in complex cases, and is talking about bringing that to the general public. Tools like this, while powerful in the hands of people, could also further erode trust and expertise of health professionals. So do you have any thoughts on that?
I'm sorry, I'm not looking at the
comment.
Is it?
Oh, do you want me to read it again?
Oh, yeah. I just see that.
Okay.
Yeah, that's interesting. I think, my response would be that our public is continually having more and more access to information. And I think I see, again, our role as practitioners or public health officials as navigators of that information. And so while it's great and it's important that the accuracy of whatever information people are getting is potentially improving, that there is still a role for that, that human navigator or that expert to help guide people in that information. So I don't think it's potentially a bad thing that these tools are in the hands of people. I think not people not having access to tools when they're available, I think it would further erode trust. So I think it's important to again, be transparent, continue in dialogue, and see ourselves as not the all knowers, but as also users of these tools and navigators and helping people navigate decisions in concert with this information.
Yeah, I mean, I would share in terms of healthcare now, there's this some of an example of an AI tool that's being used now is not about helping to diagnose the disease. It's about taking notes for you during the patient visit. And I think all of us who've gone to doctors in the last several years find it dissatisfying, as do the doctors, that they are all too often focused on the computer and not even looking at us because they're filling in these, the electronic medical records, which requires paying attention to the fields and moving the cursor. And the increased attempts to come up with what's called a sentient app that can listen to the interaction between the doctor and the patient and draft the notes so that the doctor can look at the patient and pay more attention to the patient, and then later maybe look at those notes, is a potential wonderful tool. But it's also not perfect. And I've heard some docs have said, it means I can go home and see my children at a reasonable hour. And others have said, I don't feel like it's perfect yet. And I end up having to correct too much in terms of what it's drafting. So I think this is a field that's just developing so quickly that, maybe a year from now, there'll be a great tool that just is so wonderful in terms of capturing the nuance of a patient and doctor interaction. The problems with it won't be as they are now. It will be less and less of a problem. I think these are good tools that could potentially be useful. We just want to make sure they work well, they don't become problematic, but in fact they help. I don't know, Alejandra, have you had something like that in terms of your patient
Definitely,
interaction?
yes. Yeah, we're living it in real time in our health system. And I think, and I would say even, I won't comment specifically on the safety in the health system, but I think they're being very careful about introducing these tools in their clinical space because it's, in terms of even capturing language, it's not great. So I completely agree that it's still very much a work in progress, and we're treading carefully because it's not the silver bullet yet.
Yeah, if I can just add another perspective, in my own experience as a physician for more than 40 years, the best patient to have a relationship with is one who has spent some time trying to learn about their condition or trying to ask better questions. And so insofar as these tools can help people get a larger view, a more informed view of what's going on and what the possibilities are, and maybe to help inject into the conversation some ideas that hadn't been thought of yet. It's just a better partnership. And so in that kind of an interaction, I can see, some real benefit. I can also see that in the public health space because of the same thing. If you're working with a community that has had the tools to help them learn more about what's being done in other communities, they'll bring ideas in that you might not have thought of yet. And so that's really helpful. I mean, that's the whole idea of health literacy, right? We're trying to improve health literacy 90 different ways. And this is one really wonderful way to take advantage of, even if it's not perfect.
I think you're so right. I'm so glad you raised that. When I started out in public health, I was working on HIV, and HIV patients couldn't find what clinical trials were taking place. It was really hard, and their doctors often just didn't know. And there was a lot of sort of very intensive old school research to try to make sure that the HIV patients had the tools to ask their doctor, can I go into this clinical trial? And now that's much easier to do. Someone sitting at their computer with a ChatGPT could say, for their particular disease, is there any research that's going on in the country that they should be aware of? They could get pretty accurate information pretty quickly. Not perfect, but certainly more than was possible in the past.
It really contributes to the potential of bilateral learning.
Yeah.
Because, the patient isn't the only person who's learning, or the community isn't the only group that's learning. The system also has to learn. And these are some of the ways in which the system can really improve its learning. So super interesting point that somebody raised about Oh gosh, hope I didn't lose it. I love what you guys are saying. It's wonderful. The audience is just being so
Yeah, the
participatory.
audience is amazing. They are the experts.
Thank you so much. Let's see here. Oh, I know. I wanted to ask, this is a really good question. So what can we do to empower employees within tech companies in their jurisdiction to resist unethical directions and support organized public opposition to initiatives that are counterproductive to the public's good? So how do we get people in the tech companies to understand what some of the issues are?
That is a good question. I mean, I can give you a specific example, and I don't know if it's related specific. I'll just give it a specific example. The work that when we were working a lot for patient portal implementation in the county, we, the EHR companies are all kind of out in the Midwest, and there's not a lot of conversation between those big EHR companies and the one that we were working, that was the provider for the county and us. And so as we were doing work, there was a lot of things that we found around the use of patient portals in our population. And I'll give a very specific example. The fact that our patients, it was phone first, and then computer, laptop, tablet second, third, fourth, right? It was very important that the most usable version of that portal, accessible version of that portal, be the mobile one. And initially, it was the not great version. Like you would have to get on the desktop to get all the functions of that portal, all of the accessibility to the services. And the second class version was the one on the mobile. And so it was really important when we found that we actually engage in conversations with the developer of the people working on the EHR side, and I actually started forming a work group with them. And eventually, over the next couple of years, given that formative research, we're able to change it so that the platform was mobile first. That the best version of the portal was the one on the cell phone, and if that was the priority versus just being like the usable version on a desktop. And that was really important for access for our patients. And so I think we were the ones that initiated that, but I think as public health officials, as providers, when we see these on the ground problems, maybe we have to take the first step in forming, whether it be, a new collaboration or a work group with these companies to be able to engage in that change. Because we certainly didn't have that forum, but now we do. And now we have people who are able to, they go there and they meet with them, and we have these work groups, our patient portal work group, that's able to provide information about, new updates that we need to make. So I think, maybe a version of that is one thing that we have to put on the table in active engagement. Just like community members, a stakeholder, these tech companies that are producing the products are stakeholders as well.
And my inclination would be to go back to that slide that Alejandra showed with those 5 points on it, and to say that our expectation is those 5 need to be incorporated into development and design, and in negotiation about buying products or working closely with the company. I think asking those questions makes good sense. And again, to really feel like you can ask those questions, the work at the community level, the work at the public health level needs to be well informed about why those are so important. And I think consistently saying, what are you doing with those, can be heard eventually, I think, by the tech industry as questions you're going to have to grapple with. So you should be prepared to incorporate that kind of thinking into your work.
So one of the issues that came up, which I really think bears some thinking about, is in those departments or those institutions where the decision makers are saying, no, you can't use AI for anything, don't even think about it. How can people who are at more of the on the ground level be able to influence their decision makers, the people who are their supervisors? In what ways can they open up a conversation? Can they bring some examples that would perhaps provide some comfort to the people who are in the position of having to answer the policymakers, who may have all kinds of issues around AI?
Yeah. Maybe I'll start,
Yeah,
Alejandra.
that'd be great.
I've gone to a number of different statewide public health annual association meetings where this gets raised, and it's sometimes raised in states that are more liberal as well as states that are more conservative, which is interesting. I would say the starting point, for me, has been that I would encourage people to use is to understand what the concerns are,
Yeah.
because they're often the same concerns. The number one concern I've heard when policymakers have put this in place is concern that private information, particularly healthcare information, will be inappropriately shared. A second concern is that those hallucinations or false information will occur. Um, so I would say really making sure you understand why is it that the policymakers felt like it was too dangerous or inappropriate to use AI, and then speak to that, because there really are answers to that. There have to be very strict rules that are put in place around the privacy of people's health information, particularly where there's any possibility at all of identifying the information with a particular person. But there are very clear steps that can be and are being taken to make those protections, just like they are already being done with infectious disease and other medical records. We put in place protections. We need to make sure that those are in place in those communities where the concern exists. Now, if there are other concerns, that's a whole other story, but listening to what the concerns are and then providing ways to address those concerns and take them seriously, not belittle them, I think is the way to move forward.
Yeah, I agree. I think understanding the concerns and, when you think about resistance in the workforce, I think the ones that I hear the most, and we've talked about them, obviously, we've talked about the concern for bias. I mentioned that, it's a whole concept of digital divide and excluding people, but speaking to that point, there are ways to address it. And so I think there are solutions, but we have to be activated. I think the other ones also that I hear a lot are around like job displacement, right? That people will be replaced. But speaking to the point of the community health workers, for example, we can actually improve their job and upskill them, augment them. And then this whole concept of, oh, it's just about the algorithm. No, this is, human judgment combined with technology to help make better decisions for people. And so I think, yes, understanding the risk or the tension and then trying to craft unique solutions, again, guided by those important principles that we mentioned at the beginning for the framework in digital health equity.
Okay, well, pivoting once again, I'm wondering if either of you have some good examples of how AI tools have been particularly helpful with serving rural communities or tribal communities. A lot of times people think we're just focusing on what happens in the urban centers, but I don't think we are. And I do think that if you have any ideas of examples, that would be really helpful to lift up now.
Should I start, Alejandro?
Yeah, that would be, thank you.
I would offer an example both in communication and in surveillance. I think in communication, the AI gives us greater capacity to make sure that we're using the right language and the right cultural framework in terms of communicating. You can design systems much more effectively that allow you to have materials available, as we both have been saying, and Alejandra said in detail. So that's communication. On the surveillance side, I would say one of the challenges that often comes up in terms of rural and tribal communities is that the population, because the populations are not dense populations, it's hard sometimes to get to statistical significance or to be able to draw any conclusions from the data. And as a result of that, those populations sometimes just get ignored because the epidemiologists feel like we just don't have enough information. We might make a mistake because the population is so small, and then if are looking at a disease or a subpopulation, you don't know whether or not you're seeing something that's real or it's just an unusual occurrence. And what increasingly AI is being used for is doing forecasting, is taking historical data, trying to think about how to be able to be more granular and provide some useful insights. This doesn't mean you make things up. It means you try to look at trends over time, you try to use multiple data sources, you try to think about conclusions you could draw with unusual combinations of data sources that may allow you to provide more useful information to the populations that in the past have just been not counted.
Very
What do you
helpful.
think, Alejandra? Does that make sense?
That makes a lot of sense. And I think the other thing that I think the applications from rural and tribal communities, as well as just the process of not just how accurate is this AI, but how deciding how it's used. Is, the whole concept of like data stewardship in those populations, I think is really important. And I think will be a model to learn from, given the concerns for privacy and whatnot, that, I'm not the expert on indigenous data sovereignty, but this whole concept of community-led data trust. And I think those models will be very important as well for us who are in the urban areas and who are in LA, learning for how those boundaries are applied in those populations. I think that will be sort of that model will be augmented as well across the country.
Maybe I would also just add that I think this question reinforces that you need to be there needs to be funding, there needs to be
Yes.
technical expertise,
Yes.
there needs to be attention to those communities so that they can in fact use the tools, the AI tools, to improve the way that public health has historically functioned. If the resources are only in the largest communities or in a select number of communities and not focused in at the tribal level or a rural community level, it's unlikely that we're going to see real improvements in terms of access to data and access to information from those communities.
Okay, well, I hate to wind up the conversation. I know that people's brains can only absorb so much at in one big bolus, and I'm sure that that folks are getting ready to really seek out their next cup of coffee. But I really want to thank both of you, Alejandra and John. You just did such a good job of bringing up so many points of view. The audience, you were amazing. You really contributed well to the conversation. You helped shape it, and you brought up a lot of questions for our next webinar in the series. And there's a lot of things that we're hoping we can just get back to personally on. So thank you for those of you who shared resources. I tried to capture as many as I could and put them into the chat. But again, the video and the slides will be available next week at the dialogueforhealth.org website. Save the date because we're projecting our next one will be on September the 17th. So thank you to all of you for participating. It's a really important topic. There's so much more to say, so much more to share. And if you have any ideas about questions or issues we should be raising, please don't hesitate to send them in. So this was a great webinar. Thank you, everybody. Bye-bye.